Good afternoon, students. I want to welcome you once more to this online lecture. And this week, we're going to talk about treatments and technologies in women's health. So, women's health is an important aspect, needs to be dealt with. We need to discuss it exclusively because the woman biology is highly unique. And to start, it's important to understand what hormones are and what they do. So by definition, hormones are chemical signals that are secreted in the body that act on distant tissues, usually in a regulatory fashion, meaning that once they are secreted from one part of the body, they enter the blood stream and are transported to the entire body, and then they act on specific tissues, and once their role basically is they do that in a regulatory manner. Now, what is the role of hormones? The basic role of hormones basically is to orchestrate or induce responses in other tissues. And in fact, when you look at such kind of responses, they vary in nature. Yes, the effect can be rapid, slow, brief, diurnal, or long-term. So the effect of hormones in their response, they vary a lot. And also it's important to know that the effect of hormones can be mimicked, means can be simulated. This can also be stimulated or can all be blocked by therapeutic drugs, nutritional and environmental chemicals. So basically indicates the point that the effect of hormones are quite sensitive. So I'm quite sensitive to all these factors. And hence, as we discuss the human biology, especially women's biology, we need to reflect on those characteristics of hormones. So let us now look at the female reproductive system. So as you can see on the slide, there's a drawing of the reproductive organs of female. So firstly, you can see what looks like arms, and those are fallopian tubes. At the end, they look like fingers, opening fingers, and holding something, white thing. And what they are holding basically is an ovary. An ovary is an organ where the women's eggs are developed. And you can see in the middle there, we have the uterus, the body of uterus, and also the surrounding muscles called the fundus of uterus. These muscular structures. And of course, we have the vagina, which is the opening to the outside of the body, and followed by the cervix, which is a structure that limits access to the uterus by a narrow channel into the uterus. Okay. Having said that, let's focus on the ovary, because when we look at the woman biology, what is significant is their reproductive system, the way it's designed in such a unique manner. And if you look at the ovary, this is where the women eggs are produced. So we'll look at the structure and the function of the ovary. Firstly, we have what they call our primordial follicles. Primordial follicles, as you can see on the picture, these are basically represents a pool of non-glowing follicles from which all dominant pre-ovulatory follicles are selected. So as you can see on the picture there, on step 1 we have what they call primary follicles. This is where the eggs basically develop from, so that the process can develop and then eventually mature and released. And if you see on the second stage is you see a growing follicle, and you see an egg developing at the center of the follicle. And with time, that egg basically matures and into a structure which is called mature follicle. And this mature follicle, meaning that it is almost ready to be opened and release the egg to the fallopian tube, to the other reproductive organs. And you can see on step 4, it's basically the opening of the follicle, the mature follicle, releasing the egg, and that's what they call ovulation. And if you look at the egg, structurally, you can see that in the middle is the egg, but surrounding it is what they call protective tissue. Protective tissue is important so that the egg is not damaged. And after that, the follicle continue its journey to step 5, where the empty follicle eventually begins to reduce in size and degenerate. At step 6, we have what we call corpus luteum, and indeed it's an increased structure of follicular structure, and soon after that we have corpus luteum regression in size and structure. So this is but what is key also about the ovary is to understand the fundamental reproductive units of the ovary. Basically, what is known is that all the reproductive units, which are the eggs or ovums, are formed in ovaries from birth between 6 and 9 months of gestation. So which means during growth stage, no new ovaries are made, meaning that women, they have pre-made number of eggs, and that number, as they grow, keeps reducing. So between birth and menarche, the number of primordial follicles begins to go down, reduce from several million to several hundred thousands. In fact, only 400 will complete development and undergo ovulation and corpus luteum phase. And the rest die by atresia. So it's important to understand that the rest of the eggs basically degenerate and die out. Yes, and having said that, let's look at the organs. The organ that is responsible for producing hormones that regulate sexual reproductive, system in women. So we have what they call the control center, also called the hypothalamus and pituitary glands. So the control center, it harbors, or it houses, it keeps, or it houses the hypothalamus and the pituitary glands. And these are the glands that are responsible for producing hormones. And the major parts of these glands, firstly is the first one. Number one is called the hypothalamus, followed by pituitary stalk. Thirdly is by pituitary gland. And the fourth part there, as you can see in front of the eye, is called olfactory bulb. Olfactory bulb. Okay, we see how these organs perform their duty in releasing hormones to control or regulate the female reproductive system. So on this slide, we have the pathway for how hormone production is done from the ovaries. So as we can see on the left here, we have a figure, or rather a drawing of hypothalamic pituitary gland axis. That's where basically its hormones are released, and once these hormones are released from the hypothalamus affecting or controlling the pituitary gland, and once these are released into the bloodstream, basically they go to regulate the reproductive organs. For example, in the female, it's in the ovaries, and the same hormones in males, they actually regulate the processes in the testicles. And so in the female ovaries, basically they are responsible for the secondary sexual development of secondary sexual characteristics, and also fertility at puberty. And the same applies to male. And what happens is that, within the hypothalamus, you have the you have the gonadotropin releasing hormone, which basically once released, it influences it regulates the pituitary. It induces the pituitary to release follicle-stimulating hormone and luteinizing hormones. And these are hormones now that circulate into the blood, going into the reproductive organs, which are the ovaries and the testicles. And within the female ovaries or reproductive organs, you have the release of the estrogen, progesterone, and testosterone. And these are what they call sex steroid hormones. So it's important to know that these hormones that are released from the pituitary gland basically go to ovaries to regulate the release of sex steroid hormones. Okay, on this next slide, we have basically synthetic pathway for these sex steroid hormones, right from the from cholesterol, as you can see from the cholesterol biosynthetic pathway at the level of pregnenolone. There you have the pathway branches into the production of progesterone from pregnenolone, and that goes further on your right. There is the production of androstenedione. If you go down, that leads to the production of estrogen. So that's another sexual hormone. And if you go further to the right, you have the androstenedione leading to the production of testosterone. And further down, you have the estradiol, which is made from testosterone. And in between there are hormones and the enzymes that catalyze these processes. And as you know, testosterone is the male hormone. Yes, so basically this is how these hormones are made. Let us focus now on the estrogens, which are the female hormones. So we have the first group of estrogens, because there are a number of there are two major groups. The first one is called steroidal estrogen. Steroidal estrogens and the non-steroidal estrogens. Under the steroidal estrogens, we have the first group known as natural estrogens. So these natural estrogens basically with the following names: estradiol, estrone, and estriol. So basically these are most biologically active estrogen. Estradiol is the biologically active and the major estrogen circulating in premenopausal women. So for women who haven't reached menopause, this is the hormone that is biologically active in their system. And the estrone is a major circulating estrogen. Post-menopause, so after the menopause, you get estrone circulating into the blood, regulating the reproductive system and other things. So within the steroidal estrogens, we have the second group, which is then synthetic estrogens. So as the term suggests, synthetic, basically these are man-made, made from chemicals in the form of drugs, as opposed to the natural estrogens which are produced in the body by the body system. So the synthetic estrogens are as follows. We have the first one, ethinyl estradiol. Second is menstruanol. The last one is long-acting injectable preparations. So we have a group of long-acting injectable preparations or drugs. Okay, let's move on to the next group of estrogens called non-estradiol estrogens. Under this category, it's important to know that these are hormones that are isolated from natural sources and also from and those which are also synthesized. So, and also it's important to know that the affinities for estrogen receptor, they vary a lot from weak to highly potent. So there's a broad range of potence. So among the natural non-steroidal estrogens, we have phytoestrogens. As the name suggests, phyto means plants. So these are estrogens that are derived from plants. For example, lignans and isoflavonoids. So these are some of the estrogens, phytoestrogens. And they also the hormones that are derived from seeds, for example, sesame and linseed, and also from soybeans and green tea. And usually these phytoestrogens are weak estrogens compared to the natural steroidal estrogens. And among the synthetic non-steroidal estrogens are what we call synthetic. Our first group is the stilbestrose. Stilbestrose followed by clomiphene, tamoxifen, and raloxifene. So these are the groups of synthetic non-steroidal estrogen, purely made from chemicals. Okay. So, as I said, these hormones, including estrogen, are produced from the ovary and enter the blood, and their effects, or they are targeted to various parts of the body. And as you can see from this slide, basically from the ovary, estrogen act on the breast, to develop the breast from for example, at the puberty, when the breasts begin to enlarge in size. Of course, they also influence the uterus as one of the important reproductive structure, the vagina, and then also urinary tract. The estrogen also influenced bone structure, the heart function, the blood vessels. Also, they regulate the skin, fat, the bowel, the liver, and the brain. So you can see that estrogen has multiple roles and influences a number of organs in the body. Let's look at the specific roles of estrogen. Firstly, the estrogens, they promote formation of female secondary sexual characteristics. Okay, so these are characteristics that we'll talk about them. We'll talk about them later. For example, when secondary characteristics such as enlargement of breasts and enlargement of hips, pubic hair, etc. And also estrogens, they stimulate endometrial growth. So this is the structure within the uterus that that maintains, or that forms the carpet, or the part where the baby actually implants. And yes, the estrogen also, they increase the uterine growth. So it influences the uterine, especially inner parts, to grow and prepare it for the baby, to increase muscles and make it comfortable for the embryo to develop into a baby. Estrogens also increase vaginal lubrication. So lubrication is important, so that during copulation, which is a sexual act, the sperms, once they release in the vagina, is highly lubricated and wet enough to allow the sperm to swim and allow the sperm to flow into the cervix and enter the uterus. And also estrogens are responsible for thickening the vaginal wall. Yes, and also reduces the bone resorption. And in so doing, it increases bone formation. So, which means that without estrogen, if estrogen levels are reduced, it means that the bone structure basically begins to lose its density. However, with the production of estrogen, there's an increase in bone formation. Also, with the supply of estrogen, there's a surge in estrogen levels, which induces the release of luteinizing hormone, which then triggers ovulation by releasing the egg from the Graafian follicle in the ovary. So basically, that's the ovulation process, how estrogen is involved in the ovulation process. Okay, let's look at the next hormone, which is progesterone. Progesterone converts the endometrium to its secretory stage to prepare the uterus for implantation. Meaning that once progesterone is released, it influences the uterus formation and prepares the uterus, the endometrium part of the uterus, for the implantation of the embryo. And also progesterone affects the vaginal epithelium and the cervical mucus, making it thick and impenetrable to sperm. If pregnancy does not occur, progesterone levels will decrease, leading to menstruation. Okay, so it's important to understand that progesterone is a pregnancy hormone. Once released, its role is to prepare for pregnancy. So it allows this development in the epithelium of the vagina, and also cervical mucus increases to block, just in case there are sperms that are released when fertilization has happened. So that will block further sperm from entering. Okay. And during implantation and gestation, the progesterone appears to decrease the maternal immune response to allow for the acceptance of the pregnancy. This is an important process, because once the egg has been fertilized and an embryo begins to develop, if the immune system is at its full capacity, highly responsive, it will recognize the embryo as a foreign body and will elicit antibodies to destroy it. So one of the roles of progesterone is to decrease the maternal immune response. So it's like an immunosuppressor. So it's an immune suppressor therapy. Yeah. And just so that once the embryo implants itself to the placenta and begins to develop, there will be no counter immune response to reject the embryo. Hence, the baby will develop. Progesterone also inhibits lactation during pregnancy, which means the fall in progesterone levels following delivery is one of the thing that triggers the milk production. This is another important aspect, in the sense that once pregnancy is been established, progesterone will inhibit the flow of milk, because at that time the baby has not been born and there is no need for milk. So progesterone will inhibit the production of milk. And also, the fall in progesterone levels after delivery is what actually triggers the milk production. Okay, so let's look at the phases of female lifespan. So it's important to understand the lifespan of women, because it's highly unique from men, in the sense that, you know, women are designed like especially the women reproductive system actually expires. It has a limited time, and then once it reaches a certain period, once it expires, it begins to degenerate and becomes inactive. That's what they call menopause. So let's look at all these various growth phases in the lifespan of female. Firstly is what we call pre-pubertal, or also called fetal, infancy, childhood, and pre-puberty. So it's pre-puberty. Basically, it's from the time the fetus is made, and once the baby is grown in the infancy and childhood, up to pre-puberty, followed by pubertal phase. This is when now the female goes through the puberty changes, physiological changes. After that, we get what we call pre-menopause. This is just before menopause, also called reproductive phase. This is the time that women have to make babies, and because after the pre-menopause is over, their reproductive system shuts down, and hence phase 4 is pre-menopause, or rather perimenopause, followed by menopause, or also called menopausal transition. So this basically is a transition to menopause. Just before menopause is a process that prepares the woman's reproductive system to complete shutdown, complete menopause. And then we have what we call post-menopausal phase. So here is the remaining part of the lifespan of the woman after the reproductive system has completely shut down, and it is also accompanied by a number of physiological changes in the body that we'll talk about later on. Okay, so let's look at the puberty in girls. What really happens in girls at puberty? Firstly, at puberty is where girls experience the secondary sexual characteristics appearing. In 95% of the girls, this happens between 8.5 years to 13 years. And at this stage also, the girls, they experience breast development, usually between the age of 10 to 12.5 years. And also, they develop pubic hair 6 months after breasts start. They develop pubic hair, and also before breasts. It can happen before breasts in 1 out of 3 girls can have literally the opposite. And also, is what we call growth spurt. This growth spurt basically happens a year later. This is a stage where girls begin to put on weight, develop hips, and become, become round and beautiful. And yes. And this is also the time when they experience what they call menarche. Menarche basically means the first time that the girls experience menstrual period. And this is usually happens between 12 years to 15 years. And it happens as the growth spurt wanes down. And the mean years is 12 to 13 years. So menarche an important phase in the girls, indicating basically the start of their fertility phase. Okay, so this is basically a graph to represent all that what I talked about. For example, the height spurt, menarche, breast development, pubic hair. Excuse me. So yeah, also here the graph indicating basically the various developmental stages. For example, on top there is the ovarian cycle, and as you can see, from day 0 to 14 days, ovulation occurs. Ovulation occurs at the 14th day from the time the egg starts to develop. So it goes through the growing follicle until ovulation. After ovulation, it takes another 14 days, as the corpus luteum develops and eventually degenerates, and starting the cycle again. In terms of body temperature, you can see that the body temperature usually is slightly above 6%, and as it reaches ovulation, 14th day, the body temperature increases to 37, and it stays high until until a few days after that. A few days, what is called luteal phase. So the luteal phase, eventually, if there is no pregnancy development, the body temperature begins to go down. If you look at the anterior pituitary hormones, the levels of anterior pituitary hormones, which is the luteinizing hormone and follicle-stimulating hormones, you see that there are peaks at ovulation, meaning that the levels increase at ovulation, and it simply tells us means that these are hormones that actually prepare for the development of the ovary, and the release of the ovary, and ensuring that the ovary, or the release of the ovum rather, and then they play a major role. And you can see the ovarian hormones such as estradiol and the progesterone levels further down. You can see just prior to ovulation, the estradiol levels go up, and then soon, immediately after the ovulation, it goes down, and then it increases slightly and goes down. But also what is interesting is, if you look at the purple graph, the line is presenting progesterone. Yes, progesterone, they gradually go up. Once at ovulation, there's a almost exponential increase in the levels of progesterone, meaning that there's a high level of progesterone production to prepare for the pregnancy. And if pregnancy hasn't been established, they begin to go down. The levels go down. If you look at the uterine cycle, you see that the uterine cycle, it initially from day 0, it reduces. Let's go down to the lowest level, and at ovulation, the uterine cycle, the level of uterine cycle also increases in terms of the blood, and the endometrium develops, increasing the level and increasing the amount of blood supply into the uterus. And you can see soon after luteal phase, if there's no pregnancy, that uterine cycle or the uterine endometrium basically breaks down. So that's where you see blood, basically coming out of as period in women. Okay, so let's look at fertilization. Soon after the release of the egg, during ovulation, it's important to understand how the fertilization happens. Amen. So we see on the left here is diagrams. Firstly, diagrams on the extreme left that show the flow of hormones, and their role in fertilization. As you can see from the hypothalamus, you have the gonadotropin releasing hormone, which influences the pituitary, excites the pituitary to release the luteinizing hormone, and then the follicular stimulating hormone to the ovaries. Once these two hormones reach the ovary, that's where now they induce ovulation. The cycle, we spoke about it, basically is the release of the ovum or the egg, and once the egg is released, it enters the fallopian tube and begins to migrate upwards. And as it does so, and at this stage, if they are sperms, what they do once released in the vagina, they enter the cervix and they climb very quickly, very fast through the uterus. They enter the fallopian tubes to meet the ovum. In fact, at this stage, once the egg is released, enters the fallopian tube, the sperms are already there. And the first one that enters the ovum basically succeeds to fertilize the egg. The rest are held back. And from that time, this mitosis begins, cell division. First you have the 2-cell structure, 4-cell, 8-cell within the fallopian tube, and in the process migrating towards the uterus. And once it reaches uterus, there is what they call implantation of the blastocyte. So it is planted. Now, if we talk about fertilization, the question is, when is the peak of fertilization? The peak of fertility is actually 2 days before and 2 days after ovulation. These are very critical times, that when a woman has unprotected sex with a man, most likely she'll get pregnant, she'll conceive. And the ovum may be fertilized for up to 48 hours after it is released from the ovum, while the sperm may survive inside the uterus between 48 to 72 hours on average. And the maximum days that the sperm or can survive is about 5 days. Okay, now let's look at the menstrual cycle. Basically, menstrual cycle is basically a normal, in a normal cycle, it can be between 21 to 35 days. So again, you see there's a broad range or a difference in terms of the normal cycle, because it varies from individual to individual due to various factors. Now, the cycle can be affected by pregnancy and breastfeeding. Once a female is pregnant, the cycle is disturbed, is actually shut down. And also, breastfeeding also helps to inhibit the cycle, menstrual cycle. Also, extreme exercise affects the menstrual cycle. So when instead of having a normal cycle, the person who is undergoing extreme exercise may experience prolonged, periods. Quite often experienced, characterized by a lot of pain and and also extreme weight gain and weight loss also influences the menstrual cycle. Stress is one of the factors that can affect the menstrual cycle. So speaking about stress, it just reminds me how women nowadays are into women who are working into what was originally meant to be men's job. For example, working underground, in the mines, underground mines, is mainly for men because it's quite stressful, but because of women's rights and it's because of also socio-economic factors, women are allowed to work underground. But in so doing, it's important to think to remember that such kind of physical stress may actually influence their menstrual cycles. In fact, it will be a good study, especially in South Africa where you have a lot of mines, to conduct a study on the menstrual cycles of women who work underground, to see how variable and how their experiences are, and how the mining stress, the stress out of their work influences the menstrual cycle and other related things. Okay, so medical conditions can also influence menstrual cycle. Conditions such as the thyroid disease, polycystic ovarian syndrome, this can affect the menstrual cycle. And of course, medications. There are certain medicines that influence menstrual cycle, especially the obvious one, which is the pill. The pill basically is the contraceptive medicine that is taken to prevent pregnancy development. So, yeah. Okay, let's now move on to the contraceptions. Let's understand what contraception is and the various options that are available. Okay, so depending on the reproductive system, the gynecological history, the medical history, the religious or cultural considerations, and the personal choice, these contraception options will vary based on these factors. And the first contraception option is what they call abstinence. Abstinence is where you abstain from sex for a period of time, especially just around ovulation, 14th day, let's say 2 days before and 2 days after ovulation. If you can abstain from sex at that time, most likely you will prevent pregnancy. You will avoid pregnancy. And of course, there's another option which is called the natural, or let's say a rhythm method. This is okay. Let me qualify my earlier statement when I talked about abstinence. Abstinence basically is complete cessation of sexual activity, which means you don't engage into sex anymore. Yeah, that's abstinence. Then we have what we call natural and rhythm method. This is avoiding sexual intercourse in the most fertile part of the cycle. And as I said earlier, around ovulation to mid-cycle. Yeah. Now, there are 3 types of contraceptions which are normally used. The first one is called the barrier method. Second one is hormonal method, and third one is structural or permanent methods. Okay, let us look at the barrier contraceptives. We have firstly is the male condom, which most of you know. Male condom is a structure that has been is a barrier method that has been designed to prevent pregnancy. So it's the physical barrier to sperm entering the uterus. Okay. So with the male condom, it protects against STIs, which are sexually transmitted infections. That's the advantage of condoms. Also, the latex or polyethylene, polyisoprene. Basically, these are materials that have been used to make condoms. Latex is like rubber, rubber and plastic, such kind of material. Usually, such material is very cheap and widely available, and they are easy to use. They are very easy to use. In terms of failure, there's 2 to 15% failure rate, meaning that it's not 100% foolproof. You can have failure, especially when the condom breaks or if it's expired. If it's expired, it cannot sustain the physical pressure on the condom. It usually breaks, and that can be dangerous because then sperms will be released and will be allowed to flow into your uterus. If there are sexually transmitted diseases, then the couple that is having sex will be exposed to disease risks. Okay. Now, what are the problems associated with condoms? Firstly, it's incorrect use. Usually, men are not taught the proper skills on how to use condoms. So usually the problem is incorrect use. And because of this, quite often the condoms break, and or sometimes the condoms just fall off while in the sexual act. Okay. And sometimes when the latex, some people are allergic to the latex, the rubber that is used to make condoms, and in so doing, they might experience some convulsion. Okay, still on the barrier contraceptives, let us look at the female condom. So female condom is made of nitrile. So, and it's 95% effective. So that's quite effective, way much better than the male. And it protects against STIs. However, the problem with the female condom is that it's more expensive than the male condom, and not as widely available. That's a problem. Also, it's noisy. When in use, actually, it makes a lot of noise. Okay. Then another barrier method is called diaphragm. Diaphragm is a dome-shaped object made of silicone, and it's inserted vaginally prior to intercourse, before having sexual intercourse, and must be placed over the cervix to be effective. The idea basically is to close the cervical opening to prevent sperms entering the cervix, and it can be used if you can't have hormone preparation or if the individual is breastfeeding. Okay, so what's the key here basically is a good option for women who cannot take hormonal preparations or are breastfeeding their children. And then, yeah, so in terms of efficacy, it's 88 to 94%, which is quite high. However, the problems associated to the diaphragm is that they don't protect the individuals against STIs. And sometimes you get toxic shock syndrome, which is rare. The shock from the diaphragm, the way it is planted, sometimes it can create shocking, let's say, shocking pressure and waves and things like that. So, yeah. Okay, let's now look at hormones. These basically are hormonal contraceptives. Hormonal contraceptives, basically, they work by inhibiting ovulation and fertilization. And also that, they are only available for women. So it's not for men, it's only for women. And now there are different types of hormonal contraceptives. The first one is called combined oral contraceptive pill, or CP. Okay, we'll talk more about this. And then we've got the progesterone only pill, progesterone subdermal implant, injectable progesterone, vaginal ring, and progesterone intrauterine device. So quite a number of methods there, hormonal methods. The first one is the oral contraceptive pill. I think this is quite a common pill to most of women in their households. So this pill basically is a combination of synthetic estrogen, mostly ethinyl estradiol, and progesterone. So it's a combination of those two hormones. And there are several types available. For example, we have 28-day packet. So meaning that you have to take this for 28 days before you go to the next cycle. And it consists of active or hormone pills for most of the cycle, meaning that you have to take these pills every day. In those 21, 26 days, it contains lactose within the pill. There's lactose. This lactose pill basically is an inactive pill, usually taken at days 2 to 7 days. Yeah. And if you look at the pill itself, you notice that the last 4 are white in color. So I suspect those are the lactose pills. Okay. And also contains different doses. There are different doses available. And also it's also characterized by what is called monophasic. Monophasic meaning that you take the same dose during the cycle and you don't change the dosage. It's also compares to what is called multiphasic. They are contraceptive pills which are multiphasic, and they have the dosage basically varies over the cycle. Okay, so there are 2 options there in terms of dosage, and it acts by inhibiting ovulation. The efficacy, meaning the efficiency, is 99.7%. So if we look at the OCP, or oral contraceptives, in terms of benefits, they are cheap and easy to use. They may control bleeding issues, or called dysmenorrhea, and the heavy bleeding. So it may control those kind of health problems. May also reduce acne and hirsutism. Okay. Hirsutism basically is the facial hair. Yeah. Yeah. And let's look at the contraindications. Contraindications meaning these are conditions which in which when people experience such condition, they must not use OCP. For example, past clots in leg or lung. If a female is is experiencing blood clots in the leg and lungs, must not use contraceptives. Also smokers, people with heart disease, currently breastfeeding, must not use. Other medications also must not use contraceptives. Also, there are problems associated with OCP. For example, it's not protected. There's no protection against STIs. And ovulation may occur if missed pill. If you miss pill, most likely ovulation occurs. So the point is, once you start taking them, you must never stop. You must continuously take them according to the prescribed cycle. And these pills are not suitable for women over 50 years of age. Okay, then the potential side effects include bleeding, nausea, headaches, breast tenderness, fluid retention, and plasma. Plasma basically is skin pigmentation. Okay, let us look at the hormonal contraceptive called progesterone only pill. So this is a pill that contains progesterone only, also called mini pill. Okay, it acts by thickening cervical mucus, as we saw earlier, so sperms cannot fertilize the egg. also, or it alters the uterus lining and can inhibit ovulation. And also can be taken by breastfeeding women and those who can't take estrogen. So it provides a better option for people that cannot take estrogen. 99% effective. And if taken at the same time every day, you get very high efficacy. Okay. The only problem it has is that the bleeding. Individuals under this kind of pill may experience bleeding, and also there is no protection against STIs. Yes. Okay. Let's look at the progesterone rod. So this is also called Implanon. And this is a small flexible rod which releases progesterone gradually. It can last for 3 years and usually is inserted in upper arm, like you have seen on the picture there, showing the direction at which the implant was inserted. And it prevents ovulation and thickens cervical mucus, so sperm enter uterus. Makes the uterine lining unsuitable for pregnancy. Okay. And that's how it prevents pregnancy, by disrupting the pregnancy process. What are the advantages of mini-pill? It's 99.9% effective. You don't need to remember a daily pill. You drink as you go. Usually reduces bleeding. So bleeding can be light or non-periods. Okay, so we have the cost effectiveness of such kind of pills is one significant point to mention. The problems with progesterone rod is that the small procedure that is needed to insert the rod may expose the patient to bruising afterward effect, and also bleeding issues. Sometimes you get bleeding. Also does not protect against STIs. Okay. Okay, and okay, let's move on. Let's look at the injectable progesterone. Yes, the first one. Okay, injectable progesterone, also called depomedroxyprogesterone acetate. So these are injectable, given every 12 weeks on the upper arm or buttock, and they act by inhibiting ovulation, and their efficiency or efficacy is between 94 to 99.8%. And the advantages of injectable progesterone is that they don't need to remember a day pill. As you can see, every after 12 weeks, and usually reduces bleeding to light or no periods, and is cost effective. The problems associated to injectable progesterone is that there's loss of bone density, weight gain, and also experiences headaches, bleeding issues, and it does not protect individuals against STIs. Okay, let us now look at the next hormonal contraceptives called vaginal ring, also known as NuvaRing. Okay, so this is a soft plastic ring which contains estrogen and progesterone, and it's inserted into the vagina for 3 weeks, then out for 1 week, followed by insertion of a new ring for another 3 weeks, etc. And it acts by inhibiting ovulation. Yeah, it is contraindicated, and is contraindicated as per OCP, oral contraceptive pill. It is contraindicated. It's effective, 99% effective. Okay, let's look at the problem associated to the vaginal ring. It's usually the discomfort with using it. The cost is a bit too much. It may not stay in the place while having sexual intercourse, and also there's no STI protection. Let's look at the progesterone IUD. IUD as in intrauterine device. So this is also called Mirena. And this is basically a small T-shaped device with progestogen in the stem. So as you can see, the stem there is filled with the hormone progestogen, and it acts by thickening cervical mucus. It thins out uterine lining and may also inhibit ovulation, and it's 99% effective. The benefits of intrauterine device is that you can last for, or rather it can last for 5 years, and reduction in bleeding and cost effectiveness. So these are the 3 major benefits of such kind of device. The problems associated to this is that there is a procedure to insert. It's very uncomfortable or quite uncomfortable. No STI protection and cramps. So individuals might experience cramps and expulsion. Sometimes the device may be expelled out of the uterus and through the vagina outside. Okay. And so still on the intrauterine device, it's made out of copper or multi-load. It's inserted into the uterus and by doctor, gynecologist, or trained GP, and it stays in that place for 5 to 10 years. Yeah, so that's how it is. And then also, yes, effective 99%. The benefits, it's cost effective and can use if you can't have hormone methods. This is a good option. However, the problems associated to this kind of contraception is that there's potential for infection with insertion, meaning during the process of insertion there's a potential of infection, transmitting infection. Also, is painful, heavy bleeding are experienced, may be difficult to insert. Sometimes you have women who have tiny uterus. Yes. Okay. Let's move on and go to the permanent form of contraception in female is called tubal ligation. Tubal ligation basically is a procedure to block the fallopian tube so that sperm cannot meet the egg. Okay, and there are 3 ways of doing so. Firstly is what is called cauterized. Cauterized, basically, this is where they cut the fallopian tube, and then it's like they solder. They close the ends using a specific device. Or they can tie and cut. They tie both sides and they cut in between. Or they can apply what is called banded. So say like a rubber band, and then they just by twisting the fallopian tube and tying a rubber band to block the movement of any material that can happen. Yes, okay. So more about this permanent female contraception. So this is a new procedure. It's more. There's a new procedure called Eshua or Ishua. Basically, here is a small micro inserts placed into each fallopian tube via the vagina and the cervix and uterus. So the new procedure called Eshua, basically what it means that once they insert this small rod into the fallopian tube, at the point where it is, basically it develops like cystic fibrosis, an inflammation, like a permanent inflammation blocking the fallopian tube and basically blocking the flow of any ovary that is released cannot pass, and also sperms cannot go in. So it can be reversed by about 50% of the women having full pregnant or ectopic pregnancy, which is common. It's okay. Let's talk about men. The permanent contraception in men. In men is called vasectomy. And basically this is a procedure to prevent sperm traveling from the testicles into the semen. And the surgeon, actually what the surgeon does is they cut the vas differential, which is the sperm tube that connects the testes to the uterus or to the penis. And it is successful in 99.9%. Yes, the problem associated to vasectomy is that sometimes you get bruising. Bruising may result while cleaning up, and also this discomfort. This surgery exposes you to discomfort. Also, it's difficult to remove. Or yes, and there's no pregnancy is not guaranteed if a reversal procedure is undertaken. So once these permanent methods, you need to be careful before you decide. Because once you decide, it's permanent. Okay, let's talk about the premenstrual syndrome. So basically, this is a physical and emotional symptoms before the period that women go through. I want to challenge men. From today, you observe women around you very carefully, especially at home, your sisters, etc. You notice that actually during this period of menstruation period, women quite often they experience what they call physical and emotional symptoms. We'll talk about this. So basically the symptoms end with the start of the period. And anyway, we get this the symptom basically mild in about 75% of the people, and they also get severe symptoms in about 20% of the population. And there also is higher incidence in smokers. So this syndrome is quite high in smokers and obese, especially obese women. Okay, so the PMS symptoms are as follows. So this is what happens prior to menstruation period or during menstruation period. Is women who have abdominal bloating and fluid retention. So they get bloating, they get abdominal pain. Also they get acne on the face, anxiety, confusion, yes, the clumsiness. So there's depression and lowering. Yes, they also experience depression and lowered mood, difficulties in concentration, and memory lapses. Okay, so the man will also experience digestive upsets, including constipation and diarrhea. Okay, then also drop in self-esteem and confidence. So just watch the women once they are sitting quietly docile and looking lost. Most likely they are going through such kind of symptoms. Also, drop in sexual desire. The sexual desire just goes down, or occasionally an increase in sexual desire. Those are extreme cases. Also they experience feelings of loneliness and paranoia, the food cravings, headache and migraines, hot flashes and sweats. May also have increased appetite, increased sensitivity to sound, light and touching. Now, this is the time when you have, if you are married to a woman, if you try to touch her, she, hey, don't touch me, or they'll move away quickly. Just know that they are going through such kind of symptoms. Irritability, including angry outbursts. Women experience this sometimes. So for men, please just observe this carefully and don't get angry with them. Just be nice to them. Yes, and the mood swings, weeping sometimes, and the sleeping changes, including insomnia or excessive sleepiness. May also have swollen and tender breasts. Yeah, so this PMS symptom actually affects a lot of the women. This is why I said, women have a unique reproductive system. Okay, now how do you manage PMS? First, you need to look at the lifestyle. What can you do with the lifestyle? You need to exercise regularly. Yes, walk, jog, walk about 10 minutes, jog, and then do some exercise, go to the gym. Yes, don't smoke. And women must stop smoking. And then reduce caffeine and alcohol. Also sleep well. And as much as possible, reduce stress. Yes. And then also there are treatment options. For example, the pill helps to reduce PMS. and the antidepressants such as SSRI. These are drugs that will help to reduce PMS symptoms. Vitamin B complex is good. Even in primrose oil is also good for treatment of PMS. Okay, it's important also to know what polycystic ovary syndrome is, because this is quite a common problem in women. So it's greater or equal to 2 of the following symptoms. Polycystic ovary syndrome is including 2 or more of the following. There are 3 here. First, it is chronic ovulation, chronic anovulation, meaning the stoppage of ovulation for less than 8 cycles per year, which means that the ovulation is being affected, negatively stopped sometimes. Also, we may experience hyperandrogenism, which is clinical or biochemical, involving, including, for example, in clinical, there is acne, there is asceticism, alopecia. Basically, these are some of the symptoms that you may experience in women. For example, loss of hair, acne on the face, and and then with the biochemical symptoms, you get a raised testosterone, and also plus or minus precursor hormones. Yes, the third issue within this POS is the polycystic ovaries. So when you have polycystic ovaries, this is, as you can see under their pictures showing polycystic ovaries. For example, the one on the left compared to the one on the right. The one on the left is less holes, and the one on the right is got more holes. These holes basically indicate the presence of the presence of the cystic fibrosis. Yeah. Now, polycystic ovary syndrome, basically, the prevalence is about 6 to 18% of the population. And the cause usually is unknown, but it's a combination of genetic and environment factors. And it's been shown that weight gain may promote the phenotype of polycystic ovary syndrome in a susceptible population. Also, the health implications is that the reproductive system is affected. For example, the fertility and the cycle, basically fertility, the cycle irregularities, the irregularities in the menstrual cycle. And when it comes to cosmetic, there's acne that develops on the face. You get asceticism also, and metabolic effect. For example, insulin resistance may develop, and you get also weight excess, and lipid abnormalities. These are some of the health implications of polycystic ovary syndrome. Okay, still on the management of PCOS is the lifestyle. You need to have a good diet and also exercise. That combination of good diet and exercise must be maintained, and aim for 5 to 10% weight loss. It's very important to lose weight. Okay, so in terms of cosmetic, you can have laser treatment, or oral contraceptive pills that may help. Also, anti-androgens. Next is menstrual irregularity. So with this, basically, you can use oral contraceptives. They'll help to regulate the menstrual period. And then infertility, because this polycystic ovary syndrome may lead to infertility. You can also use a drug called metformin that is going to assist in the reproductive system. And psychologically also, you need psychological support to such victims. Okay. Then let's look at the menstrual cycle with regards to estrogen and progesterone. It's important to note that, you know, when it's before menopause, you see the levels of estradiol, for example, increases sharply just prior to ovulation. Once ovulation has occurred, it drops drastically. So it's like within a day or so. And then also, then you get also progesterone on the other end, which we talked about earlier. But it's interesting to note that post-menopause, all these hormones, their level is flat, represented by the red line. And that's what the major implication is. So, okay, let's move on, and then let's talk about menopause. What is menopause? Menopause basically is defined as the last menstrual period. So this can take, for some use, definition of 6 to 12 months of no periods. So if you're experiencing that, maybe it's a beginning of menopause. And then also you have natural versus surgical. So for example, removal of ovaries, often at times of hysterectomy. So you can enter menopause if you block the fallopian tubes, normal menstruation. And usually this happens at an average age of 51 years. Individual women that reach that time, they begin to experience the menopause symptoms. So basic physiology involves the cessation of ovulation at that stage and loss of cyclic ovulation, production of estrogen and progesterone. So they are no longer produced at menopause. Perimenopause, this is the time from when symptoms and signs of approaching menopause begin until 12 months after the final period. So this is a stage prior to the menopause. And it involves irregular cycles. So women will go through irregular cycles, both in terms of length, volume, and pattern of flow of blood, and hormone secretion. Okay, so women may experience menopausal symptoms prior to the final menstrual periods. And approximately 1/3 of cycles ovulatory, meaning that during this period, basically 1/3 of the cycles are ovulatory. The 2/3 are not. Yes. And then the median age of perimenopause is between 45.5 years to 47.5 years. The mean duration of perimenopause is 4 to 6 years. So it's important to know this. What are the symptoms of menopause and perimenopause? So this is the basically in 20% of the people they experience from no symptoms at all, and then suddenly they get the following symptoms. So, for example, they have hot flash, feeling very hot and sweaty, and also night sweats, and also vaginal dryness, anxiety, mood swings. So this time women go through such kind of symptoms. You get also depression, incontinence. Incontinence is loss of control over urination and defecation. And then you also get frequency and memory loss and lessened concentration, fatigue, muscle joint pains. So these are some of the symptoms of menopause and perimenopause. Okay, let's talk about hormone replacement therapy as one of the options for treating symptoms of menstruation or menopause and perimenopause. So this is basically a pharmacological preparation containing an estrogen and or a progestogen. Okay, 2 hormones, sometimes 1 or 2. And estrogen is for symptom relief, whilst progestogen is for uterine protection. And estrogen exposure every day, basically you take every day. And progesterone basically taken in a sequential or cyclic regimen for example, for 10 to 14 days per month, and resulting in a bleed, or daily continuous combined regimen and there's no bleed. So there are 2 options there. Okay, HRT. No. Now, what is the current role of HRT, hormonal replacement therapy? Yes, usually it's for use in symptomatic peri or postmenopause women with no contraindications. Okay, so for example, past clot in leg or lung, women with breast cancer, women who have heart attacks or stroke must not use this therapy. Okay, short-term use is like less than 5 years, and it's available preparation, systemic formulation, for example, tablets, and transdermal skin patch. Also, you have gel estrogen, subcutaneous pellets, or implants. There's different formulation. Also, available preparations, for example, is vaginal preparation, pessary, estradiol, and also creams. So yes. So in this slide, basically, the aim of this slide is to show the risks and the benefits of hormone replacement therapy between 50 to 59 years old or less than 10 years after menopause. And we see that on the left side, on the y-axis, for example, on the top panel, you have hot flashes and vaginal atrophy. Symptoms on the left were worse, but after, for let's say, from 0 number of women per 1,000 per 5 years of use. Those who don't use, they've got symptoms are worse. And then as you go in the number of women per 5 years of use, with the increase in years, much of the use leads to better symptoms in those hot flashes and vaginal atrophy. However, in other symptoms such as fractures, diabetes, breast cancer, coronary cancer, colorectal cancer, overall mortality, etc., you notice that those parameters are not highly significant. There is not much change at all over the 5 years period. Now, then after menopause, the same treatment, HRT, what was noticed that, the fractures, there was more benefits in fractures, more a reduced rate of incidences in fractures. There are more benefits. Diabetes, for example, was a reduction in the number of people with diabetes. And then, breast cancer. Okay, so with breast cancer, we see that for those who take estrogen, the risks are high. But those who take estrogen only, without progesterone, the white bar is a estrogen plus progesterone. The black is estrogen only. So with the breast cancer, we noticed that the risks of those who are taking a combination of estrogen and were much high. Yes. And, okay. Sorry. And then, what are the adverse effects of using hormones? So when using estrogen, these are the adverse effects that patients may experience. For example, headaches, migraine, nausea, breast tenderness, or sometimes swelling of breasts. May also experience local reactions. For example, rash with skin patch, mood swings, fluid retention, weight gain, breakthrough bleeding. In terms of progesterone, with progesterone you get low moods, irritability, and then headaches, fluid retention, abnormal bloating, breast pain, weight gain, and breakthrough bleeding. So these are some of the adverse effects of each of those drugs. Okay, so that brings us to the end of the lecture. This is references for more information. If you want to read more and learn more, please follow those references. Thank you so much for your time and for listening. Hope to see you next week. Take care of yourself. May God bless you. Amen.